Importance of diagnosis. So we have Dr. معيقل. He is associate professor in King Saud University in neurology. He specializes in geriatric and cognition. So please welcome with me, Dr. Taim.
Assalamu alaikum rahmatullah. Thank you for the warm introduction. As this was mentioned, kind of a very important topic, kind of a very dynamic topic about diagnosis. And it's actually, preparing this, it's kind of hard to keep up with all the new studies that keep coming out and explaining all the new ways of diagnosing Alzheimer's disease. So let's get started. All right, so we're going to go ahead and do a quick background review on Alzheimer's disease. I think that's been hammered into your thoughts already by multiple talks. I won't take a lot of time with that. We're going to address the changes that have happened with the diagnosis and discuss all the biomarkers that are being used in Alzheimer's disease. So obviously we had a great talk right now by Dr. Najib talking about how prevalent Alzheimer's is with so many cases, and most cases of dementia being of the Alzheimer's type. It's now being theorized as a chronic process, and by that I mean an extended chronic process, because it's always known to be a chronic disease, but it really starts decades before, the disease itself starts decades before any symptoms develop. All right. So Alzheimer's disease, the most common cause, especially in those over 65. And typical symptoms are going to be memory, short-term memory, visuospatial problems, language problems, executive dysfunction. And it's common to see an unawareness of illness among patients. Basically, amyloid fibrils accumulate into extracellular space, and these are not soluble, so they're hard to eliminate from the brain. Eventually, certain structures that are involved with neurotransmitter release are also damaged, and there's lots of neuronal loss. And so you end up with a deficiency of neurotransmitters like acetylcholine, the one we currently target with our medications, and as well a group of other transmitters. So one of the main problem here, as we mentioned, is the lack of the clearance of the amyloid beta from the tissue. And the preclinical stages could extend up to a few decades before the disease actually begins to show any symptoms. And if you look here at the prevalence, just showing the importance of age as a role from a different from the Framingham study. And in fact, this study was done based on clinical data before use of any biomarkers. So it could be that these numbers are higher, or the curve might be pushed to the side if they had biomarker studies at that time. So the incidence increases as we get older. 65 years of age is a cutoff for late onset versus early onset disease. Still, most of early onset dementia is going to be of the Alzheimer's type. And these other sporadic or familial forms or young forms, they all tend to have the similar clinical course. The ApoE is an important susceptibility gene, and I just like to mention it because it is not per se a way to diagnose the disease, but it's a marker or determines or indicates that there's a higher risk of developing the disease. And there's some other susceptibility genes such as TREM2, SRL1, and such, but none of them have a potent effect, let's say, as much as the ApoE. There's some few studies done in Saudi Arabia looking at its prevalence, and as you can see here in the slide, there's the Saudi data and international data. Sorry, there's no laser pointer, but you can see that the prevalence in the more recent Saudi data is pretty similar to that of the international data. And if you look at the table down in the bottom, you can see how the age of onset of Alzheimer's becomes even earlier with homogeneous forms of ApoE. So, importance of diagnosing Alzheimer's disease, because a lot of times when people get older, they don't just develop Alzheimer's disease, there's a process of having mixed pathologies. So 31% really just have Alzheimer's pathology, whereas others can have a combination of synuclein, like coexisting Lewy body, for example, or TDP-43. We cannot neglect the importance of vascular disease, which is prevalent in almost half of patients. And I think as demonstrated in one of the earlier talks, you can get hippocampal disease and atrophy that is not directly related to Alzheimer's. So as people get older, even in the oldest old group, you get a decline in, you actually get stabilization or even a decline in the rates of Alzheimer's disease, but an increase in hippocampal sclerosis, for example. And so it's important to identify these other processes when we're going to make our treatment decisions. So what's a biomarker? It's a diagnostic biomarker is an objectively measurable characteristic used to indicate a pathogenic process to improve diagnostic accuracy. So using the example of mixed pathology as neurodegenerative disorders, which can happen in over 70% of cases, with cerebrovascular disease being the most prevalent one, you can see how it'll be a challenge in determining the exact cause for the patient's symptoms. So, when you want to use a biomarker, you want to make sure that this biomarker correlates well with the underlying pathology, and it's going to distinguish pathology from normal aging, and it can distinguish the target disease, for this case, Alzheimer's, from other diseases. So over the, say, decades, when Alzheimer's first started out, diagnosing Alzheimer's was based a lot on clinical exam. But early in the 20th century, they also had some pathological findings, in the post-mortem exam. But later on, imaging was developed in the 1980s and 90s. People were able to identify regions of atrophy, particularly the temporal and parietal regions. They were able to identify the pre-dementia state, which is a mild cognitive impairment. But then later on, in the beginning the second decade of 2000s, the biomarkers were introduced, diagnosed in the CSF, or you can find them through imaging with different modalities. Right. So the important biomarkers that I'm going to focus on today is the amyloid, the tau, and neuronal degeneration. Okay. So the U.S. National Institute on Aging and the Alzheimer's Association put forward this system they call the ATN system, which is amyloid, tau, and neurodegeneration. And it kind of allows for a formula to help you diagnose Alzheimer's disease. So with this development, instead of going from normal to MCI to dementia, they'll be able to identify even an earlier state, like a pre-MCI state. And even people have started taking subjective cognitive impairment more seriously, because some of these patients do progress to Alzheimer's despite not finding anything on their neuropsych exam. Right, so going into the ATN system, so these are abnormal proteins that are highly correlating with the presence of the disease, as we'll see. And these proteins and abnormalities start pretty early. So if you're looking at kind of the last curve on the right, we can see there's clinical decline in function. So much has happened way before of amyloid deposition, for example, and then followed by tau deposition. But usually you'll see once tau starts to, its presence becomes noticeable, then you'll see clinical changes. So this table will kind of summarize how to kind of interpret your findings if you have any a combination of these biomarkers. So if you're negative for everything, then that's a normal clinical state. The next state, which is highlighted in the beige, is the A+, where you have amyloid. Now, this is kind of considered an Alzheimer's spectrum, or considered an Alzheimer's state or an amyloid state. So if you have the amyloid and you have the tau with it, then that's an Alzheimer's disease condition, whether there's neurodegeneration or not. But if you don't have the amyloid, then the pathology, whether there's tau or not, then the pathology is considered non-Alzheimer's pathology. And this is regardless, too, of the cognitive state. You can be cognitively unimpaired, have MCI or dementia, and fall into any of the patterns of the ATN guideline. So the amyloid fibrils that are formed, they come from their precursor, the amyloid precursor protein, and they're insoluble. They all have a common beta sheet conformation. Different diseases will have amyloid deposition, but the one in Alzheimer's related to amyloid precursor protein. And amyloid beta 42 or A-beta 42 is the degradation product of APP, and this remains in the interstitial fluid of the CSF. So if you want to go to the, just a quick review of the amyloid cascade, where you have APP degenerating or being degraded on the secretase pathway on the left, which is the alpha secretase pathway, which is usually the one you would prefer, but instead in Alzheimer's there seems to be a preference for the second pathway, which leads in amyloid beta formation and deposition. Tau is the other protein, and it is associated with microtubules in neurons, mainly found in the CNS, and it's important for the structure and integrity. And it can come in different forms. It's responsible for the neurofibrillary tangles that we see in pathology, and it happens when tau becomes hyperphosphorylated and thus insoluble. And this is a marker for degeneration. And now Alzheimer's disease has become the most common tauopathy, but there is a whole list of other disorders that are associated with tau deposition as well. Right. So there is an association between tau, amyloid beta, cortical thickness, and this has been looked at in some earlier studies. So in this study, for example, when they looked at 106 patients, all of them were amyloid beta positive, and they had different clinical states, either subjective impairment or MCI, or diagnosed with probable AD. And so they found an association with their clinical performance. So most patients with prodromal AD, or even Alzheimer's disease dementia groups, a strong association was found between the increased tau and reduced cortical thickness and neuropsychological performance together. In the pre-MCI states, the association was strong mainly with tau, but later on, in the disease state, the association with all the markers was significant. Imaging is another tool. It's used to, or a useful marker, you can say, to identify neurodegeneration. Most of us are familiar with MRI and CT. It's helpful in excluding other conditions, hemorrhages, microhemorrhages, and changes of hypertension and such. And of course, the atrophy in specific patterns. And so this slide kind of demonstrates Alzheimer's disease up on the left, where you can see there's prominent hippocampal atrophy bilaterally, compared to relatively preserved hippocampi in image B, which is a Lewy body dementia patient. One that can look like Alzheimer's disease is down there, the SD, which is semantic dementia, one of the frontotemporal dementias, where it looks like there is a bit of hippocampal atrophy, but there's also a lot more lateral temporal atrophy on that side. And the asymmetry is very prominent. The last image shows kind of more of an image that we're used to seeing in clinic, is where there's a lot of white matter changes going along with that. So this could be white matter disease, vascular dementia, could be a combination of Alzheimer's disease and vascular disease. Right. PET scan is been around for a while now, especially FDG PET, and it's important in detecting, or it can demonstrate areas of decreased metabolism, and which correlates with areas of synaptic dysfunction. And the main regions you can see are in the PET are in the precuneus, the posterior cingulate, and parietal and temporal regions. And it can be helpful in differentiating different Alzheimer's types. And so if you look at the first image and then the second image where the red colors represents areas of the hypometabolism, the bottom image is an amyloid beta scan, which we'll go to next. But you see the areas of amyloid, which is red, is correlating as well with the FDG PET. All right. For amyloid PET markers, these have been developing over the years. They start out with Pittsburgh compound B initially, and then that's developed into multiple other agents. The accumulation of amyloid beta is slow and it occurs for a long time, even before clinical symptoms appear. And sometimes it might decelerate in accumulation once the disease process begins to start. But you can find it normally in patients. And initially, when this came out before discovery of tau, there was a lot of caution in interpreting amyloid beta scans. All right, so there are many different types of tracers. And so they all had a different uptake value ratio, and so they standardized a centiloid scale to help with measuring how much amyloid is present, to get an idea to compare with the different tracers. So if you look at young controls, they usually have a mean 0 of centiloids, whereas mild to moderate AD will have on average 100. And for example, from one study, you can see that 20 centiloid would indicate an approximate 20% plaque density. And I think most studies have settled at 20 centiloid as a good cutoff on the amyloid scan. And when compared with other diseases that do not have amyloid process, for example, frontotemporal dementia, the centiloid score was quite low. Right, and so this is the amyloid, two different amyloid tracers in the patient above with Alzheimer's disease, clearly showing high levels, and compared to a young control who is negative. These are both our patients with MCI. Image B indicated had positive amyloid, and this patient eventually did progress to dementia over time. So tau is the other protein, and we use, or fluor-tau-sapir is the other agent used which is approved, and there are other tracers being researched. And it is quite specific for Alzheimer's disease. A lot of data is emerging that it's very supportive of the diagnosis. And this particular study in 2008 was very helpful. It found that it was about sensitive and specific in almost 90% of cases, and able to differentiate from other cases quite well. As you can see, the areas of distribution of tau were different from Alzheimer's dementia compared to controls, behavioral variants, FTD, semantic dementia or Lewy body dementia, just based on the location or the anatomical uptake. It was even useful in differentiating the different subtypes of Alzheimer's disease, the dysexecutive type, the visual type, or the posterior cortical atrophy type, or the language variant. Right. Going into the CSF, we've got amyloid beta 42 is probably reduced by 50% of normal levels in the CSF of patients with Alzheimer's disease. So you're looking for a low amyloid beta in the CSF. The aggregation of amyloid in the extracellular brain tissue is kind of what leads to this low level in the CSF. The ratio is helpful when you compare the insoluble amyloid with the soluble type. And the changes might occur even before the PET scans in a few cases. But the imaging provides evidence of the extent and the location of the disease, which is not always clear just with the CSF marker. Right. Okay. The amyloid beta 42 correlates well with the amyloid PET scan. Patients who had undergone PET and CSF analysis in one study found a very strong or very high AUC, area under the curve, as well as the Uden's index. And they had suggested some cutoffs for the amyloid level in the CSF that would be supportive. And this has been done by several other studies, which I'll show. But you can see in this study, a big difference, the red triangles represent patients with dementia, or those who were positive, sorry, on the PET scan. And they all fall in the range with lower levels of amyloid beta on the CSF analysis. Those with dementia of the Alzheimer's type, those with MCI from the Alzheimer type, and even in one of the subjective cognitive decline patients who ended up being Alzheimer's. So you can see there's a high sensitivity and specificity for these agents. And looking at several other studies, they all kind of showed a range of around 700 picograms per ml, perhaps is a reasonable cutoff for determining a low. But of course, you'd always have to check with the laboratory that you'd be working with. CSF tau, particularly phosphorylated tau 181, is increased in Alzheimer's disease. It's not, again, similar to that, the amyloid in CSF doesn't help much with staging or the distribution, but it is pretty sensitive and specific for amyloid disease. And so tau accumulates because of the phosphorylation that happens to it, and it's secreted from neurons, right? And this seems to happen after exposure to amyloid beta. All right. And compared with pathological studies, elevated tau levels are associated with Alzheimer's pathology. And you can see the higher levels, or you need a low, let's say a small or lower threshold if you're going to compare it with normal patients. But if you're going to be comparing it with certain disease states, the sensitivity and specificity does drop a little, but it's still pretty helpful. But now what you really want to do is bring all of these things together. You want to determine where the neurodegeneration has happened on whatever imaging modality you have, determine the presence of the tau, determine the presence of amyloid, and when these taken together, the sensitivity and specificity is over 90%. So this is images taken from the paper by Jack in 2016. 2018. It's very informative of how the scans work. You can see the first scan up on the left is a patient with Alzheimer's disease, and showing the amyloid beta accumulation on the top left. The next one, the brain image next to it and below it, the red colors delineate the presence of tau. And you can see that there's some degree of atrophy on the brain, also supporting this person has Alzheimer's disease. Whereas in the next image, not that significant amount of atrophy for the patient's age based on an anatomical image, but the top image does show accumulation of amyloid, but no tau on in the second row of images. So this patient was doing fine. Okay. So you want to be careful, again, also if you're going to use strict biological diagnosis. We cannot throw out our clinical skills or tools and just rely on this, because some confusion might happen between Alzheimer's lesions and the presence of the disease. There's also the issue which we discussed about the pathologies changing once a person becomes quite advanced in age. And cognitive decline does vary in the end depending on what you're seeing in the patient. There's also the issue of mixed pathologies being important. And you can see how with advancing age, there could still be a possibility of cerebrovascular disease, which we mentioned earlier. hippocampal sclerosis, even FTDs can happen, even though they're known for happening in younger age group, but they still happen in older patients. So you want to be careful, because if you might encounter a scenario where you have and you want to know who's more at risk for determining Alzheimer's disease. So you have a 60-year-old who is ApoE4 positive, negative tau, but an amyloid PET just below the threshold of positivity, or an 85-year-old male with amyloid positive and tau positive and cerebrovascular lesions on MRI. So you want to kind of keep in mind that you have to individualize your prediction or your diagnostic strategy for each patient. Blood biomarkers have really is an important target by many researchers, because this will really revolutionize. People don't like to take blood samples, but they hate lumbar punctures even more, understandably. And so if you can start to diagnose with just plasma level of tau and amyloid, it'll be great, and there's a lot of studies showing good promise. And you can see that, initially there might have been some conflicting results with studies, but I think a lot of them now with improved techniques are proving quite useful. The plasma tau correlates with the CSF levels and the amyloid PET as well. Again, similar limitation to the CSF is that you can't really identify the locations or how much is involved. And this is just a study showing how it's got good sensitivity and specificity with one study that looked at over 200 patients, even able to differentiate from other dementia disorders. Other future markers are being researched, as like the NFL neurofilament light chain, neurogranin. These are very good for detecting synaptic disease, synaptic dysfunction. Some other PET tracers looking at different targets are also. OCT might be helpful in determining like a neurodegeneration is present. Right. So I think the best way to summarize this is to go with the International Working Group guidelines in 2021. And here you can see that the diagnosis of Alzheimer's disease is still clinical and biological. A positive amyloid and tau biomarkers can establish an Alzheimer's disease diagnosis. Physician still has to rely on the phenotype and follow up to determine the final diagnosis, because you still have to consider mixed pathologies. We've talked about the recommended biomarker measures, which is the low amyloid beta and the increased ratio, and also the increase in phosphorylated tau. A final diagnosis is after physician reviews the clinical and the biomarker results. Still more standardization is ongoing. And we don't have exact guidelines on what to do in patients who are clinically normal. Should we start screening patients? I think it's still a bit early for that, but it will be interesting to see what happens in the coming years. And thank you very much for your attention.